So accessory access in DA is not commonly required. In fact, it's become more rare over the years, but it does address these exact kind of circumstances often. So I have no disclosures relevant to this talk. What is an accessory incision? It can be really anything, but we used it most often for these large patients, perhaps, where you can insert anything from instrumentation to an entire stem, primary stem in the ream and broach systems, to revision instrumentation as well. And they're different. We'll cover a few. So, for example, in a patient like this, where it's a big guy, big dense guy, we're just saying dense muscular patient. Maybe you don't want to do everything from the front. You don't have to do everything from the front. We usually do everything from the front, but you don't have to. And if you get in a situation where it's that tight, you can use an accessory incision, like this guy. Like this was Nicholas when he had his hip done. So, or big patients like this. This is actually not adiposity. This is a big abdominal hernia, a ventral hernia. So when you actually move this patient over a little bit, there's actually not that bad a hip, but an accessory incision can still help you here. There's no amount of tape that's going to help this. Now, but to stress, this is not the two-incision technique that was popular in the early 2000s or 2010-ish. This is not an anterior incision with a posterior incision. This is a anterior incision with an incision that's really named after Dr. Kunchner. In this picture from the 1956 Campbell's, Dr. Kunchner was rotting femurs and advocating for rotting femurs at that time, and so we call this little proximal spot the K spot after Dr. Kunchner.